working. And just to note that John Archer-Jones has left the Trust as a non-exec director after 4 years, or just over 4 years. I'm sure the board would like to record its thanks to John for his work over those 4 years in primarily the Audit Committee and later on, and QDC, the Quality Governance Committee. So, any declarations of interest? No, good, thank you. And the draft minutes, the public board meeting held on 25th of March. Are you happy to refer record? I'll take that as yes. Okay, thank you. And the action log. Mark, are you going to update us on anything on that? There's one thing down against you on the action log. No.
Sorry, I was just trying to get myself off on mute. I've already failed at the first attempt, first item. And so it was 96%. It is still 96%. We're still working on making sure that these risk assessments are undertaken in due course. It's a little bit of a struggle in relation to new people joining and some people leaving, but the team are very much still on this. This wasn't a once in a lifetime issue. This is something that we're continuing to work upon.
Okay. Are we happy with the remainder of the action log?
Could I ask Alan that we get a date for the second item on there, because it's still to be confirmed, and I believe there is a meeting tomorrow for some lessons learned from the first wave, so I just wonder whether it would be timely to bring that back to a meeting in the near future. Yes, it would. Thank you, Claire. I'm just slightly struggling to spot that. For the members of the public watching us, we have a new system for board papers, so you might find one or two board members, including the chairman, slightly struggling to find the paper he's looking for at any particular time. But yes, Claire, so what do you want me to do? Well, I will work with Joe and others in the background and get a date for that on the board agenda in the near future. Okay, thank you very much. That's excellent. Right, patient story. As you know, we always start the board with a patient story. It's not necessary to remind us it's a hospital we're running here, but it is important that we constantly look at what the issues are for our patients. So, Sharon, Director of Nursing.
Thank you very much, Chair. Our patient story today is a video that we're going to share that John has contributed to. Clearly, John has been a patient as we have gone through our COVID journey. And I think it's really relevant and pertinent that we listen to his story and then talk a bit afterwards around what we've put in place to address some of the concerns he's highlighted. So thank you, Kieran, if you could play the video.
I was diagnosed August 2019. The previous 8 months I'd visited my GP on several occasions with various symptoms, bleeding, mucus, etc. Kept getting told it was piles. Eventually got referred through for a colonoscopy and then was told that it was bowel cancer. Then had another set of tests and came back and found out that it was stage 4 and had spread to my lungs. Before the COVID kicked in, there were issues with communication, but I think a lot of the time you don't understand what they are because it's all brand new. To give little examples, when I was told that I had that the cancer had spread from my bowel to my lungs, the doctor said, "I'm really sorry it's spread, here's 2 nurses that will talk to you about it," and walked out. Now, I did the research and found out that that meant it was stage 4, but it was never verbalised, which, you know, was a difficult thing to come to terms with. But on top of that, when I had sometimes meetings with my first oncologist, there were times when, and he was very good, it felt a bit brusque that we weren't involved. It was more an announcement than a consultation. So it was, this is what's going to happen and this is why it's going to happen and that's it. Which for some people might be perfect, but actually for me, I like to feel a slight element of control over that. The other bit saying about communications, just for a second, is when I had my colonoscopy. And while the colonoscopy was being done, the doctor suddenly went, "Oh God, that doesn't look good." And that was the point when I knew. Now, it only saved me. If that meant I found out 5 minutes earlier and didn't hear so I knew before I was officially told. But again, looking back, it's probably not the best way to hear it. Treatment was stopped. I was meant to have one more session, and the oncologist suggested, because of the high risk of COVID, and I'm not exactly knowing what was happening at the time, that it was safer to stop one early. And so I wasn't really quite sure whether it had stopped because they'd done all they could do, and there was no benefit for extra chemo or radiotherapy, or whether it was a case of the only reason we stopped is COVID. And it was very much, I don't know where I stand, I don't know what's going on, and that's the bit where if you know, you can concentrate on it and deal, or do something about it. It was round about August again that I got back in touch, because the pain was getting worse. So I reached the stage where I thought, if I don't push it, I had consultations, and the consultation said, I will review it. I think it was October, and I pushed it because I was just like, I'm not having another few months feeling like this. I went to see Dr. Bradigan, had the scans again to check what the progress had been. Thankfully, the bowel had not got any worse. Couple in the lungs had got worse. So anyway, thankfully she completely reviewed it from the beginning again, because I had been told at the beginning there is no way you'll ever have surgery. She reviewed it and said, actually there is the possibility of surgery, and that's what I'm now waiting for, which has completely and utterly changed my viewpoint on it all. It's been very collaborative. And what's been really helpful is feeling included within those discussions, because ultimately it is your cancer, and if you feel some control in it, that gives you strength to help fight it. The communication is a key element. You can't control COVID, you can't control everything that happens, but you can try and control communication, and making that easier for people prevents the worry. I have been lucky. I'm lucky anyway in my own life, because I've got a great family and great friends who supported me. But the support that I've received from Macmillan, from the nurses at the hospital, from the oncology unit, has been really, really good. Things were getting very difficult, particularly with me trying to return to work, and feelings of guilt for not being at work while I wasn't having treatment. And I did contact Macmillan, and I was set up with a counsellor, which really helped. But also the nurses at the hospital. I have been overawed by how we've been supported, and we could not have got through it as well as we have. I'm not saying we wouldn't have coped, but we certainly coped a lot easier with the support that Macmillan gave us than we would have done without it. It's been valuable.
Okay, these things are always quite sobering, really. Does anybody have any comments on the head of that very open and broadly supportive video, making some very clear points about communications? Jill?
Thank you, Chair. Just a bit concerned, I think, about the fact that communication is a major theme of many of our complaints, always has been. We do all we can to mitigate it, but this story really demonstrates the absolute importance of good communication, timely communication. And it's a question I was going to ask our nurse and medical director. Is this something that could be used in clinical meetings to, again, really strengthen the training and support I know you give your clinicians on the importance of good communication? Okay, I'm going to go to, Anne's hand has miraculously disappeared.
Sorry. No, I was going to make the same point, but the other point I was going to make was whether we did show this for training purposes, because how the patient feels during the process and the things that are said, I mean, it's really powerful training tool, I think. So it really picks up on Jill's point. Sorry, Alan.
No, that's fine. So we'll go to Matt and then to Simon, please.
Thank you. So completely share the concern and the sentiment, Jill and Anne, and indeed, having reviewed this story, have shared this video so that the teams, both in oncology and in gastroenterology and general surgery who do endoscopies, can hear from him in his own words the experience that he reported. And I have arranged follow-up meetings with the relevant clinical leads to talk through how they're going to use the learning from that and use it, exactly as you say, Anne, as a very powerful teaching and training tool. And in the case of oncology, whilst I would accept a partial mitigation in that they are understaffed and busy, nevertheless, and Joe and I have reviewed this, the new appointment slots for patients in clinic are between 40 minutes and 60 minutes. That is ample time to get communication right. The one source of solace that I got from listening to John's story was that after he had the news broken to him around his diagnosis with the disease having spread to his lungs, he was then seen by the cancer nurse specialist, formerly known as the designated key workers, and indeed in dealing with communication with patients with cancer, that role was really recognised as an essential component to maintaining and improving communication with patients, recognising that the news when it first hits is so devastating that often patients can't remember what happens after the first sentence. But that is not to say that we do not have an awful lot to take from this, and the suggestions that you have made have already been acted on, so thank you.
Okay, I'll change the order. I'll go to David now and let Simon come in last. David.
Yeah, my question, my substantive question was actually similar to the one that Jill has already asked, but let me just ask this. Maggie's is a charity which helps people living with the trauma of cancer. And at one stage we were talking about Maggie's investing about 5 million in a facility on our estate. Is that still going ahead, I wonder?
That would appear to be a yes from both of the Director of Estates and the Medical Director. Simon.
Thanks, Alan. So the first thing I think is, as ever, to thank the patient who, John, in this case, obviously, who had the courage to share their story with us. My question was a practical one, but also an observational one. Today, we'll be debating how we restore services after wave 2 of the pandemic. And so I'll just draw to the board's attention here the debate, which I think has 3 parts to it. One, most importantly, have we challenged ourselves to deliver the very best we can for patients? And I think as we go into that discussion, we'd be mindful to hold John's story in our heads. The second is, in doing that, are we looking after our staff? And the third is, and how are we making steps in terms of returning to a more normal situation around the money? But the question here is, for this video and for this story, have we done all that we can? Have we been as ambitious as we can in terms of restoring treatment? And that leads me to my question. Clearly, John refers to the fact that he's now waiting for surgery. And I just wondered where we were on that. Because as ever with a cancer journey, it's going through a series of progressions, isn't it? It's going through a series of steps that people live through. And clearly, we now need to reflect on, have we managed to help him with that surgery? And I hope we can answer that question. If not, we should try and answer it as soon as possible. Thanks, Alan.
Matt. You're muted, Matt. You remain muted.
Arthur, apologies. As it happens, I can answer that question. Happens to be my area of specialist expertise. It is highly unusual for a patient with liver metastases from colorectal cancer to ever reach the point of being amenable to curative treatment, in this case, inevitably surgery. It is rarely possible, and it is likely, although I'm not familiar with the details of John's case, it is likely with the sort of scenario as he described it, that after a good response to some initial chemotherapy, his disease has been reassessed and happily become downstaged, to use technical parlance, and therefore amenable to potentially curative resection. There would be no other reason to perform surgery other than the possibility of cure.
Maybe we can pick up then in our debate to honour and respect the fact that John told us his story today about how we're doing more generally on cancer recovery and making sure that patients get the surgeries and treatments that they need.
Okay, thank you, everybody. More importantly, thank you, John. I think that takes quite a lot of courage to tell stories like that, and particularly to agree for them to be used in public board meetings. So thank you for that. I think you can be clear from today we'll be using it as a training aid for all of the staff involved, and indeed staff not involved in this, to think about the impact of what they do on patients. And as Simon said, we'll be picking it up as an exemplar of how we ought to be doing, and whether we're doing as much as we can around cancer recovery, which is one of our major objectives. It's also worth noting maybe that in the group objectives, which are in the process of final development, communications is right up there at the very top. Okay, thank you very much, and thank you, John. Chairman's report. I just want to talk briefly about the operational plans that we're currently putting in, part of a system-wide plan. This is the first example of the ICS beginning to come to life as system plans are submitted rather than individual hospital plans. And that covers the first half of the year. Interestingly enough, here we sit at the end of May, and we really don't know what is required of us and the resources will be given for the second half of the current year, such as the uncertainty surrounding the consequences of COVID and other things. Nevertheless, we have to submit a plan that does exactly as Simon's just said, talk about elective recovery, talk about financial break-even, and in particular focus on our people to support their health and well-being. So a discussion at the board today, later on today, will be very much about balancing up those three drivers. And that's the question the board is being asked all the time. Have we got the balance right? And the second bit is just about the integrated care system itself. The importance for us of having two places is an NHS word for kind of local service centres, and it's important for us to make sure we win the arguments about two places. And it's important that we have a good, strong, generous contribution to the design and operating model for the integrated care systems. You know, this is an entirely new way of working for the NHS, and we haven't tried this kind of thing for somewhere near 30 years, so where we've lived in competitive land. So it's very important that we put a lot of effort into getting this right, that we don't arrive in April next year with not having done much, but alter the titles on a few doors and alter the titles on a few buildings. So it's very important that we work hard on this. Final thing I just want to reference in the report is you have today before you have a nursing and midwifery strategy. And there's 3,000 of them across the group, and the strategy also covered all the allied health professionals. I'm not going to list them because somebody would surely take offence for missing someone, but there are lots of allied health professionals. When you add those numbers in, they're well over a third of our workforce. So it is a pretty important strategy when we come to talk about it. And I know the nurse directors have put a lot of effort into this, and I know the nurses and the AHPs recognise it as a major landmark in understanding what we're going to do with the whole development, career development, recruitment, retention of nurses, midwives, and allied health professionals. So those are the three things I just wanted to highlight from the agenda and remind people about how important they are. Simon.
Thanks, Alan. So 3 things to note this morning. The first, I've already opened the conversation, but I want us all today, we're meeting in public, to feel free to ask ourselves the questions. Have we been ambitious enough for our patients? Have we taken the best care we can of our workforce? And are we doing as much as we can to make sure that we're living within our means prudently? Those are the three competing debates that we're going to have today. And it's our job to make them as least competitive as we possibly can. We've got to bring them together. And so I encourage questions, comment today on those three things. If John's story teaches us anything, it teaches us a lot, I think. Getting that balance right is incredibly important. The second thing I wanted to talk about was I had the privilege to be part of the International Day of Nurses and Nurses Day, and spend some time with colleagues out on the wards, thanks to the team, Sharon, Emily, and others that took me round. And I saw some amazing things. And in particular, I wanted to highlight Mairead, who I met on Hawthorne Ward, who'd brought together a team, I think Sharon, who hadn't been long together by the time I met them, and showed again to me the importance of ward leadership and what a difference it can make. When I walked onto the ward and I started chatting to the staff, as you do, the enthusiasm and warmth and friendliness and just genuine pride in being where they were was palpable. And I listened to Mairead talk about leadership, and it was, I felt genuinely, as I often do when I go out on these visits, humbled. And I thought, well, you could probably do my job better than I could, because some of her insights around leadership were amazing. The picture that I've got up there in the report actually is the fact that together they'd won an award for their Pathway to Excellence board, which is why I chose that picture to put up there. But I also saw other examples during the day of nursing people in our nursing workforce who'd raised money and developed a whole staff area for staff to come and have a rest. And I tweeted about some of those things. And it reminds me every single day of the creativity and innovation that our nursing workforce bring to the work that they do. And one of the things I have met with Sharon earlier on this week was to talk about, as we come out of COVID, how can we support our shared decision-making councils in our Pathway to Excellence work? I'm going to join one of those councils and start supporting it. And I think one of the things perhaps we could all think about how we can support our nursing workforce is joining one of those councils and helping them do their work, being their buddy, champion, supporter. So I'd encourage you all to think about that. There's some amazing work goes on in those councils, and I think at some point we should hear from them directly in one of our meetings. So just a big thank you from me to all 3,000 nurses across the group who every day are doing some amazing, wonderful and innovative things. The third thing I want to talk about this morning is our estates team, often the unsung heroes. And, you know, whenever you go out on a trip with Stuart, you get to go to the parts that other beers don't reach. So I got to see some very impressive new boilers on my last visit around the estate with Stuart. But more importantly, it is fantastic to see how now close to fruition our new entrance is, and what a great space that will be. It was fantastic to see the shell so rapidly emerging from the ground from our new ITU facility. And it's great to know that we'll be finishing off our paediatric ED soon. And I say all of that because despite all of the challenges we face, those are real signs of investment in the future of the hospital. They are facilities that will undoubtedly benefit patients hugely, but also staff. I think those are things to celebrate and reflect on, but also particularly to end today by thanking all of the estates team who throughout COVID have been making all of that possible, as well as doing a bunch of other stuff to keep the buildings safe and appropriate. So I wanted to just acknowledge, Stuart, through you, all of the contribution of the estates team and say thank you to them by way of close today.
Okay, thank you very much for that. You know, front entrances and new Costa coffee shops and new M&S food stores sound a little bit trivia, but if you go back to the start of the COVID pandemic and the nurse in Yorkshire crying in her car because she couldn't get any food, and you think about what having your own M&S food store in the hospital offers for our staff as support for them, both in their snacks and meals, but also in being able to pick up things on the way home after long, difficult shifts. These things are not trivial, nor are Costa coffee shops for patients and staff to take breaks in and to regenerate in a good environment. So I think these kind of investments, and Stuart and the estates team are to be praised, not just for doing that, but for thinking ahead, because, you know, they're built in a way that can take another story, another floor. They're built in a way that can be further expanded. And the new ITU certainly looks extremely impressive. Backs onto our operating theatres, so for once it's in the right place. And I think everybody will look at that and think this is quite an impressive new development. It's terribly difficult to get excited about generators and things, but you get very excited when they stop working. So the investment in that is also crucial in the long-term guarantee of the hospital's functionality. It's only a couple of years ago that the hospital had a complete power failure during the night in, I believe, February. And so this kind of investment reflects well on everybody for looking hard at the risk registers and thinking carefully about what we have to do. Any other comments on Simon's report, or indeed anything I said? No. Okay. Aileen, Hospital Chief Exec's report.
Thank you, Chair. Good morning, everybody. We've all learned to love a boiler, get as excited as Stuart gets with around that kind of thing. So we're very pleased, as everybody has said. Just a quick update by way of how the hospital's going. We are very busy. We continue to be very busy. We are still, we're almost in June, and of course we're still seeing winter numbers through the door of A&E. But all of that said, the teams are coping very well, and I'll come on to that in a little minute. At the time of writing my report, we had 2 COVID patients in the hospital. We have no COVID patients in the hospital today. Now, we don't expect that to always continue to be the case. We have occasional cases popping up, but they tend to go home, and we haven't had an ITU case for some time. And so that, you know, everything is pointing towards the direction of things getting better. So we're pleased about that. Obviously, we continue to support staff because we can't forget that all of this has happened, and we are, as I said, very busy. So we are looking after our staff as best we can to make sure that people are in a good place to be able to continue with all the work that we have to do and all the work we have to catch up on, as I've mentioned. Talking of that, we are in the process of putting in reset plans and getting back to some degree of normality and playing a bit of catch up, it's fair to say. I had, at the time of writing my report, we were about to submit something that was based on Q3 of last year, but all the indicators so far this year of month 1 has pointed towards us being a whole lot busier in terms of referrals. And so we've rebased our system plans on month 1 actuals, and Karen will nod at me just to make sure I haven't got that wrong. So there's been a little bit of chopping and changing, but it was important not to put plans in that actually didn't bear any resemblance on reality. And Joe and colleagues will talk about perhaps going into the performance report about what our referrals are looking at, like particularly in terms of cancer. And we need to keep an eye on that, because if the trajectory continues, it's not surprising with a COVID bounce back that actually we're getting many more referrals in. However, if that was to continue on the trajectory, which Joe I'm sure will talk about, then we would need to look again to make sure that we could cope with that. At the last board, we talked about the numbers of patients that we had waiting over 52 weeks, and it was a worrying number. It's still a worrying number, but I'm pleased to say Joe will come. I don't want to steal any of her thunder. I'm trying not to mention everything. But the last time we were, heading the wrong way towards 4 figures, and we're now below 400. So we've halved the number, and that's a combination of just making sure that the lists were current and validated, but actually it's the teams doing the doing and getting back to work. And so really pleased and very, very grateful to our clinical and managerial colleagues who've been really focusing on making that happen, because it's important that people have their surgery. All sorts of surgery, cancer surgery, and all sorts of surgery. I mentioned around the front end, A&E and emergency care being very busy. This week we have been doing something called Give It a Go Week, and there's lots of things and lots of excitement around that, but essentially it's changing the way we do things to make sure that we can cope appropriately with people coming through the front door, and that they're streamed into the services that need them. And that the basic premise of it is that we sort patients out as they arrive as quickly as we possibly can and get them home as quickly as we possibly can. And if that means not admitting them, preferably, then they don't get admitted, but they get sorted out there and then. So that's all very positive. And the reason why we're doing it now, A, is to show we can do it, but also in preparation for the winters and the summers to come, because we have to do something different. Things are, numbers are getting busier consistently year on year on year. That's not likely to change, or it may change, but it's not changing anytime soon. So therefore we have to do things differently. So I'm sure Joe will report back to the next board of how that's gone, but all the indications so far this week is when Matt and I and other colleagues have walked around saying, we haven't got any patients, we've moved them on, what do we do next? Well, we need more patients. So that was a slightly bizarre moment, but still all very good. So things are all moving in the right direction. In terms of cancer, we are not where we need to be, and we need to improve our consistency to make sure that actually we are not, it's not just about standards, it's about making sure that we are treating people as promptly as we can, and also working with our tertiary partners, thinking in particular of, say, Leicester, for example, who are in a similar position in terms of their numbers, and we just need to make sure that we are working together between us so that we can improve the pathway and improve the speed of which we are able to diagnose and treat patients. So that was about it, Chair, really. It's a much more positive, colleagues will talk about so I'm trying to work the technology because I can't see two screens either. Sharon will talk about the CQC and the conversations we had with them at the beginning of April. But all things being equal, it's not so bad at the moment, and things are definitely improving. There's a positive vibe, and I'm pleased to see that. So thank you.
Okay, thank you for that. You may regret the phrase "in time to come, we need more patients," but I recognise the context it was in. Tom and then Anne.
Thanks, Chair, and thanks, Eileen. Just perhaps one comment and one question. I think firstly the comment just at Quality Governance Committee last week. We also reviewed the no harm review of the 52-week waits, and as Eileen said, we were very pleased to see the numbers substantially reducing, and also a report that no harm has been identified in those long waiters to date. So I think that's a really important point to bring to the public board. The second question, I presume, Eileen, good news that we've got very few and now no COVID patients in hospital. Just given the news about the Indian variant, perhaps I don't know if there's any commentary you can share in terms of how that is playing out in the community in terms of rates at the moment, and also what vaccination rates are looking like in the community, particularly today as we hear that Northern Ireland has just announced as the first country in the UK that it will be starting to vaccinate 18+-year-olds.
I'll do my best, Tom. So obviously our colleagues at Public Health and Lucy Whiteman, who we work with very closely, and the system are keeping a very close eye. We know that we have, and I know it's in the public domain, we know that we have got particular hotspots that were being blitz tested, and making sure that Toaster, for example, I don't know what the situation is this week, I'd have to hold my hands up to that, but I think we were trying to preempt whatever it was that was emerging, because it's here, and there's no point in pretending it's not the Indian variant. But to keep on top of it and get ahead of the game is the most important thing. And we're not seeing it so far in terms of presentations at either hospital, as far as I'm aware. So Northern Ireland, they've got a tiny population. My response to that would have been they should have got there sooner, but maybe that's not what the Minister would want to hear, but that's all good. And in terms of our own vaccination programme, I spoke to Chris Pallow yesterday, and we're still going great guns. one or two hiccups around the supply chain, but nothing serious. And they seem to be sequentially working through the age groups now, and we're in, you know, as in the pack as everybody else, so on target. Simon, is there anything I've missed that you wanted to bring in with that particular around the variant and so forth?
No, there have been cases locally. Thus far, they haven't translated into a significant uptick in terms of hospital admissions. The point I would make is we had our regional review. So how are we doing comparatively across the Midlands at the end of last week? And firstly, our response to COVID generally has been praised by the Midlands team, and I think it's important that I reflect that here. In particular, I think the ability of the teams to keep core elective work going. We have challenges for sure, but our challenges compared to other parts of the Midlands region are substantially less, and that is in no small part due to the leadership people have shown in terms of keeping clinical services going. So that if there is a positive to be found from what we have been through, it's important to reflect that. I think the second thing to say is that we need continued vigilance. One of the things I think I'd be most concerned that we would be, because people do so desperately want to get back to what you might call normal life, is that some of the issues that we have faced, so some of the challenges we had around infection control, how do we remain vigilant around those, maintaining a vigilant discipline around cohorting, that I think is going to be key, maintaining testing, and particularly making sure our staff continue to get vaccinated where we have gaps. Those are the things I am very focused on. I would welcome Mark's comments just in terms of any observations he had on staffing issues, but those are the things I think we really do need to keep focused on. But the context I wanted to say was genuinely two highlights from our QSRM, our quarterly system review meeting, were our response to COVID overall, and within that, the fact that we had kept so much elective work going. Mark, is there anything you'd like to add from a staffing point of view? Because I think it's important we hear that here too.
Yes, thank you, Simon. I think just going back to the meeting and our review and looking back on our progress, I think one of the reflections that we have had played back to us, and one of the things that we know from our board meeting in March, is that we have done incredibly well in terms of supporting our colleagues over the period of the last year, and that was obviously borne out in Northampton with our award that we received in terms of Health and Wellbeing Employer of the Year. I think the challenge for us at the moment, which we've articulated on a number of occasions, is that we have a number of colleagues who are, there are a number of colleagues who are really keen to progress and to treat patients that have been waiting because of the pandemic. And of course, that's really inherently why we come here to work every day, to make sure we give that patient support. The slight challenge we have in some of our areas, if we take an, as Eileen referred to, our reset and recovery programs, the theatre staff that we are asking to support our theatres and indeed our elective recovery work are the same people that we redeployed to ITU, etc., over the course of the last year. And we need to just be mindful and cognizant of that and respectful of that and the challenges and the difficulties that has had for people as we move forward. So I think what's great about the planning submission, the quarterly review meeting, and so on and so forth, is that we are very much talking about our people regularly in conjunction with our operational activity, our patient care and quality, and indeed our financial performance. And I think long may that continue, because it is ultimately us and our people that deliver the care. And that's therefore our most important asset that we need to make sure we're looking after.
Thank you, guys. Just picking up on the vaccination rate, there are two issues that affect us that we can't do much about, really. One is the estate, and we've talked about that, our generators, our new ITU and so on. We can't do much about it in the very short term. The other constraint that has been running on the vaccination programme nationally, of course, is the supply of vaccines. And nationally, people are expecting the NHS to hit a new record of an average of over 600,000 vaccinations, first and second, a day for the next 2 weeks. Now, you don't have to be a mathematical genius to work out that you'll quite quickly move to doing everybody over the age of 18 in the rest of the UK. We're only about a percentage point behind Northern Ireland in our overall coverage. So that race, as the newspapers tend to call it, between vaccinations and Indian variants is, well, it's proving to be a bit of a sprint on the vaccination side anyway. And then Denise, then Rachel.
Thank you. Yeah, I had two brief questions. One was to do with the ED numbers and one was to do with reset and health and wellbeing. On the ED numbers, and you know, we're working with our primary care partners. I just wondered, first of all, what were the key issues and when do we think we're going to get a breakthrough and a shift in this? Because it just seems hard work to kind of get a step change, and it's so critical for us. So I wondered if you had any thoughts on when we can expect that step change in that whole urgent care pathway.
Let's hold that one and collect comments from Denise and Rachel, and then we'll see if Aileen wants to come back at that. Denise and then Rachel.
Thanks, Alan. Yeah, mine's Give It a Go week. I love the sound of that. I think that's just the sort of thing that we should be encouraging. Don't want to cut across anything that Joe may have to say, but I guess I'm interested in sort of a bit more detail of how we're doing it, where are they going to, and when we do get the feedback that I think you referred to for the next board meeting, could we also incorporate patient feedback in that, please, to see how patients have experienced what we're doing? Thank you.
Okay, thank you. And Rachel.
Just to pick up on Tom's comment about the over 52 weekers and no harm done, which I think is obviously good news, but actually I don't think we can forget the psychological impact of sitting at home waiting for some of this. You know, we heard from John earlier, and there were some key takeaways on his thoughts around needing to be in control of his treatment. So just wanted to make that comment.
Thank you. Very pertinent comment indeed. Aileen, I suspect you want to come back on the one on those points.
Okay, thank you, Rachel. Absolutely, around 52 weeks. You know, we talk about harm in terms of progression or deterioration, but if you are somebody that's sat at home desperately needing a hip replacement and can't do your daily activities, it is a big deal. So that's why we are running as fast as we can to get these cleared for all of those reasons. In terms of Joe can probably talk a little bit more about Give It a Go week. In terms of the urgent care pathway, so so NHS-INE, as you probably know, because it's been in the national press, have written out to GP practices to say we've got to go back to the more of the face-to-face type of consultations as opposed to sort of 100% triage on film or on the phone. And it's difficult, and there are lots of discussions. If you speak to any of our GP colleagues, they'll say they're run off their feet, and I'm sure they are, but I think something has my personal feeling, and it is just a personal feeling, is that it does seem to me that something has materially changed. So if you take, for example, last Monday or Monday week ago, 420 attendances in A&E. If you think our average busy day would be 360, 380, and 33 people waiting for an admission, and yet our conversion rate that day was below 20%. So really low conversion rates. So the vast majority of people that we saw clearly needed care, but didn't need care with us. And those are quite stark numbers. So we are in discussions with all of our partners, and Matt's working hard with our GP colleagues and Simon and the system to work out how do we reset that? Because I think also there's something about patients came here first. They assumed they wouldn't be able to see their GP, so they came here. And that is the reset that we need to do around urgent and emergency care. There's no doubt that we did need to see some of those individuals, and quite a number of them we were able to treat in terms of an intervention, a diagnostic, and off you go with a degree of treatment. But it's not sustainable, because if you think, you know, we're in the sunshine's coming out now, but we've been rained on forever. But nevertheless, we shouldn't be seeing numbers at this time of the year, and we wouldn't want that to increase. And actually, we just need to filter out and make sure that we are publicising across all of our comms teams how you access care, because the A&E team, and just on that day by way of an example, and it really showed, I thought, a shift in terms of the mentality of how we deal with days like that. the entire site recovered within 24 hours, and it was a whole site effort. And that was heartening to see, because there was no doubt that when Joe and I, who we regularly text about 6:30 in the morning, and it's either, oh gosh, it's going to be a really good day, or oh gosh, it really isn't, we got to get going early. Everybody responded really well, but we can't do that every day, all day. And so we do need to work, but we also need to work with our population to say, you don't actually need to come here. You can go and see your GP, you can go and see your pharmacist, you can ring 111. And it's a communication thing as much as anything else. I think that was it, Alan. Thank you.
I think you're absolutely right, Aileen, that something has changed in the pandemic, and you just talk to your friends and neighbours. They tell you how they think differently about these things, and you're absolutely right that we cannot clearly continue. And the numbers are quite stark, as you say, the conversion rate and the attendance rate. It's not that long ago I was told we had a record attendance forever in Northampton ED, and it was about 340. So we've moved quite a long way in about 2 years to almost routinely hitting over 400. Matt.
Thank you. So just on the context of urgent care pressures, I think Monday last week, we had 420 patients coming through the emergency department, which is midwinter numbers in mid-May, which is a bit clearly an alarm. And I spoke to primary care colleagues and CCG colleagues to understand what they thought might be the drivers of that. Was this about a line of least resistance in terms of access to primary versus secondary care? And it turns out, although I have not seen the data, I am reassured that the attendances in primary care are also up about 20% on what they would normally see at this time of year. And of course, that's a story that's prominent in the news at the moment. And the work that we are doing to attempt to address
Matt is clearly straining the capabilities of the link wherever he is. Matt, you've frozen. I'll give you a few seconds.
It's a horses for courses issue. And the example that we are working up between us in the system is that of chest pain. So chest pain is very often not something that cardiac in origin, not something that needs to come into hospital. And our primary care colleagues are often able to see, assess and prevent hospitalisation and manage, for example, musculoskeletal chest pain perfectly well. But if they are trying to do that on a telephone triage system, as they are often at the moment, then that makes it much harder for them to assure themselves it's not a cardiac chest pain. And so they have a much lower threshold for sending them into hospital. And so together with through the System Clinical Leads Group, we are working to refine the streaming of patients accessing primary care virtually and in person. Thank you.
Okay, I think Anne's point was, when are we going to see a significant change? And all these things matter, but to some extent, if the ICS proves its worth, then it ought to be in about the quality of those conversations and the quality of the changes of behaviour. But patients are not stupid. Patients understand where things will be easiest and best, and they learn very quickly. If you go somewhere and nothing happens, you'd be better going somewhere else the next time. So I think there's a lot of work to do around communications and responsiveness in this. Okay, thank you all for that. I don't see any other hands. Matt, your hand's still up. You might take it down for me. Thank you. The Integrated Performance Report. Aileen, you're going to run this show, turning to directors one at a time. Bit of looking back and a bit of focus on the progress we're making. On you go, please.
Thank you, Chair. So first to say that this performance report is a slight work in progress. So we are changing the format of it, and it's not quite there yet. So we will try and navigate you through it. As I mentioned in my previous report, things are pointing in a better direction, but I wouldn't exactly say that we're as comfortable as we could and should be going forward. So we do need to work on it, keeping those consistent improvements. And we will try and navigate you through the report, but my exec colleagues will just go through some of the key aspects of their portfolios, and then Joe obviously will come in and talk us through the detail and some of the good stuff that's been going on. So if I could come to Matt first, please.
Thank you, Eileen. Clearly taking the port of dread, I might just take a moment to alight on probably some of the latter points. So we are delighted to have attracted a really high calibre of applicants for the ward-based pharmacy project. For phase one, colleagues will remember that involves placing enhanced role pharmacy practitioners in the assessment areas in the emergency department to improve safety and reduce the need for admission and shorten length of stay. And they will be in and up and running by winter. And I'm further reassured that that they will have a real impact, because they are making a real difference now, where we have boosted pharmacy numbers at the front end in Give It a Go Week. I promise not to say any more about Give It a Go Week, because that will be stealing somebody else's thunder. In the field of research and innovation, a first, to the best of everyone's memory, that we have checked with in Northampton General Hospital, a simple innovation to improve medicines safety in the field of controlled drugs. It has been sort of worked up and market tested, and there is international appetite, and therefore is going into mass production. And we think that's the first time we've commercialised a clinical product here at Northampton General Hospital, one of the early dividends of our academic strategy and programme. And a really interesting innovation that we are working closely with Health Education England on, in deploying medically qualified doctors who are not on the GMC register and licensed to practice as medical support workers in multiple clinical areas through the hospital. HEMA are very kindly paying for those until the end of this financial year. And we have reached out with both hands and making sure that we're giving them a good experience, evaluating their impact and their experience and opportunity.
Yes.
And I think I will stop there. Thank you.
Thank you, Matt. Sorry, I have the last couple of seconds drop out there. I don't know about everybody else. Was there anything that anybody didn't catch that Matt needed to just repeat, or are we happy to carry on? Okay, thank you, Matt. We'll come on to then Sharon, please.
Thank you very much. So I just want to highlight a couple of things from the scorecard that's relevant to my portfolio. Firstly, I'd like to highlight the Friends and Family Test. We are now measuring we're no longer measuring recommendation rates, we're measuring patient satisfaction scores, and we are now uploading the data onto the NHS site. It's pleasing to know that our satisfaction rates that we have continued to measure for inpatient and day cases remain between 90 and 95%. But what we will be able to do as well is to be able to pick up comments going forward, so as we can do some themed analysis. The pulse. Indeed, we need to make sure that we continue to ensure that we will be ready should we have any further peak occurring. We've also, as part of the IPC work, discussed and taken to the, I'm really conscious that my screen has frozen. Is anybody able to hear me?
Yes. You've just come back in, Sharon.
Okay, I'll repeat that piece again, thank you. With regards to COVID response, I'm really pleased to report that we remain at a 0 incidence. However, we need to be ready for any further cases that come in, indeed, if we do have a third wave. We have used our infection prevention BAF and discussed that at length at our recent quality governance meeting, along with the action plan. And therefore, we've been able to provide assurance to quality governance of the work that we are doing and the actions that we have in place. I finally wanted just to mention our CPE outbreak, which took place in February and March time. We believe from our root cause analysis that it had been brought into the organisation through a patient being repatriated whilst there was critical care surge across the county. We worked very, very closely with colleagues across the organisation, and in March we welcomed a visit from the NHSEI IPC lead to look at our practices with regards to managing CPE in critical care. I have circulated the letter that was received by Kirsty Morgan to all members of the board, along with the action plan which has been completed to their satisfaction as well. And it's really pleasing to report and to have minuted that the trust remains green on the NHSEI matrix following the visit when they looked at the management of the outbreak. The final thing I'd like to mention is the conversation which we had last month with our colleagues from the CQC, with our CQC inspector, a transitional monitoring meeting where we looked at the 5 Chloes and a number of questions that sat underneath that around how we're going to provide assurance to the CQC of the work that we have been undertaking over the course of the last year. We will not get any I took part in the conversation with 3 of my colleagues, with Joe, Claire and Matt. We're not expecting any feedback directly as a result of the visit, but I have to say that as a team we were positive and I guess to say enjoyed the conversation we had. Claire, is there anything you'd like to add?
No, Sharon, I think the only thing I would add was that there was a very clear focus on IPC around COVID and also patient safety, and it was very the COVID period focused, but it was a good conversation, and it was a long 2-hour conversation, so it was very thorough, and I think we gave them good evidence.
Thank you.
Thank you, Sharon. Thank you, Claire. Obviously, we know that we've got to always be on the front foot around at all times around the CQC and when they might drop in and see us. And we know that obviously our colleagues at KGH have had a visit recently, and also NHFT. So to say that we are seeking to make sure that we're match fit at all times goes without saying. So thank you both. So not wishing to have bigged you up too much, Joe, but it's now coming on to your report. So you take us through everything, please. That'd be great.
Thank you, Eileen. Let me just start with a bit about Give It a Go Week, and there's obviously a great buzz about it today. So Give It a Go Week is part of the Discharge and Flow programme, which I will talk about when I talk about the stranded patient metric and the work we're doing there. But Give It a Go Week goes from the front door to the back door. Clinically led initiatives, as Eileen and Matt have been talking about. An example of one of those is in A&E, where our colleagues from Northamptonshire Healthcare Trust are in A&E, and they are helping us stream patients. On Monday, they actually streamed 13 patients off the back of an ambulance in to see an NHFT therapist, and those patients were then subsequently sent home. So a really positive initiative, and one that we would hope to continue, not just this week, but as we go forward. Another initiative is streaming patients straight from ambulance assessment up to the NIBEVN assessment unit. And we've kept a bay in the assessment unit flowing and empty all week to receive patients. And at the back door, we have had focus on our Brampton and Hillcote wards, and our colleagues from West Northants Council have been supporting us on the ward this week. And they've been working in collaboration with therapists, and Liz Sargent, who's in working with us, and I'll talk about Liz in a moment. We've increased the discharges on Brampton and Hillcote this week significantly. So they're just examples of Give It a Go Week, clinically led, but also led by my deputy Lee, and it's been a great buzz this week. So great congratulations to the team for that, and it will continue right into the weekend as well. So let me start with urgent care. As Eileen and everyone has noted, increasing demand, 9,326 through the doors in March, and then in April we've seen 10,264 attendances, so a significant increase in April. And one of the ways we've tried to manage that increase is by streaming more patients to our same-day emergency care and to our Springfield service. And Springfield is run by a combination of A&E, AMPs, ACPs, and doctors. and GPs also do shifts in Springfield. Just for the board to note, in terms of Springfield, we have opened Springfield until 2 o'clock in the morning to cope with the high inflow in the evening. And as Bola and I have discussed many times over the last weeks, that's an increase in cost that we did not expect to have. But we have to maintain flow in A&E, we have to maintain safety in A&E, and we have to make sure that our patients get timely treatment when they come in. In terms of A&E itself, I've noted what Eileen has said about the great engagement there. And what we're seeing now is when we do have bad days, and they still do happen, our improvement and recovery is much, much quicker. And Matt did reference last Tuesday when we started off in a particularly bad position on Tuesday morning. And by lunchtime, the team had got on top of it, working with the site team and the divisions. And they built momentum for the rest of the week. And that's something that we're now seeing more and more of. So that's really, really positive. The other thing that we've been doing in urgent care is working with a company in Europe to help us recruit acute physicians. We have got a number of locum acute physicians, but we know the value in them in decision-making in ED, but also in reduced admissions at the front door as well. We're hopeful we'll be able to recruit into our vacancies, and obviously that will then reduce our locum costs. So we're looking at things from many, many different perspectives. I would also say in terms of ED, ambulance conveyances are increasing, but again, we're looking at ways to stream patients, not just in Give It a Go week, but overall in terms of how we manage our conveyances, and ambulance handover times have improved significantly. So lots of good things in urgent care. However, the demand is placing a lot of burden on our diagnostic service, which I will come to when I get to diagnostics. In terms of stranded patients, you will see in the report, obviously, that during April, our average for the stranded patient metric was 276 and the super stranded was 91. We have launched our Discharge and Flow programme, and I'm pleased to say that Liz Sargent, who's a national expert on discharge and flow, is working with us 2 days a week. She is a coach and mentor for the wards and for our teams in terms of how we can improve our discharge processes. She's also helped us do a gap analysis of where we are against the discharge to assess national policy and what the gaps are, and that's feeding into the ICAM programme. And West Northampton Council are leading that analysis with Liz and the team, and then it's feeding into the ICAM work stream on that, and it's also a key priority for winter as well. So there's lots of work ongoing around that. There's a whole programme around discharge and flow that will continue throughout the year, and of course it's a key enabler for us maintaining our elective programme. So I'm really pleased with the work that the teams are doing on the discharge and flow. I would say that a key part of this is how the ward rounds and the board rounds work. And there's lots and lots of work ongoing on that I can bring back as we go through the year. In terms of cancer, obviously Eileen and Simon have mentioned cancer quite a bit. We met 6 of the 8 standards, but we didn't meet the 62-day standard in March. We finished at 73.5%. There are some particular problems, one being workforce issues, particularly with gynecology and oncology. I'm pleased to say, though, that we now have appointed another gynecologist who has started. So we now have 2 gynae oncologist surgeons, and that will help us drive down the waits for surgery in gynecology. And oncology, we have had workforce gaps. I'm pleased to say we have appointed locums who will be coming online during the end of this month and June. As Eileen has said, demand has increased, 31% increase in demand in March, which was sustained in April as well. And this is placing a real strain on our diagnostic service. And that was one of the reasons, again, why we filled the 62-day standard, because of diagnostic issues. We're looking at many ways to increase diagnostic productivity and diagnostic capacity, which I will come on to. The good news, however, around cancer is we are meeting the faster diagnostic standard, which is 75%, and we achieved 86.5%. And we've been measured on this from Q3. So there are some good things to note. And in terms of how the legacy patients are being managed, there's real scrutiny on that. At the minute, there are 47 patients in our backlog, our legacy backlog, 18 of which have got treatment planned, and 4 of which are with our tertiary providers. There's a daily focus on this, and that's both a clinical and managerial focus. We also carve out our capacity for cancer patients in terms of surgery, and we will continue to do that. I will continue to oversee that myself. In terms of RTT, really good news, as Eileen has referenced. We continue to hit the median weight. So in fact, we're below the median weight target at 8.5 weeks. 52 weeks, when I was here back in March, we were at 723. I'm pleased to tell you we finished April at 463, but as of today, we're 370. It's fantastic work from the teams who've really taken the mantle on this. We've agreed our trajectory. They're working really fast through booking patients, making sure we get our patients in quickly, talking to our patients, and ensuring that we can hit our trajectories around that. I also talked last month about the 45-week position and the 40-week position, and there are slides in the pack today detailing that. I'm really pleased with the progress around that, because that is a key. We have to really focus in on them so those patients don't get to 52 weeks. Capacity is clearly key for that. We are obviously booking our capacity to the max, and I'm really pleased to say that the day surgery unit will be open as of the 17th of June, and equally pleased to say that orthopedics will be working full-time next week on the 1st of June. Orthopedic
okay,
patients.
let's pause for thought on that while Joe comes back to us. Okay, Joe, you're nearly finished.
Am I back?
Yeah, I know. Yeah, you're nearly finished. I'm going to take questions on any questions on those three direct before we move to the final two from Matt and Bola. There's a lot of operational detail in there. Oh, wait a minute, I'm going there. Right, David, then Anne, then Simon, and then we'll move on to the two other exec directors. Conscious of time, everybody, so I'm sure you know where the breaks are occurring. I would hate you to lose them.
Yeah, thanks very
David,
much.
Anne, yeah, go.
Yeah, thanks very much, Alan. Matt, I just had a question for you on the medical support workers, and this is very interesting given the fact that clinicians are a scarce resource. They're not particularly elastic in terms of supply, given the training times and so forth. Is this a program which is aimed towards getting these folks registered, or is it a standalone program which will be ongoing?
Yeah, really interesting question, David. So I think at the moment, first of all, it will be fair to say that HEAM came to us and asked us for our clinical assistance program, which we launched at the beginning of COVID, where we recruited a load of Year 5 medical students and some medical qualified but unregistered, unlicensed practitioners, and deployed them to the wards. And the medical support worker program is very similar to that, and I think that's probably partly why they've come to us to roll it out in the first instance. And I think HEAM are just seeing where it goes, and we sort of grabbed it by the scruff of the neck a little bit. So I've got a QI fellow evaluating the experience of the medical support workers in terms of their pastoral support and indeed their clinical the clinical utility of the exposure to them, and also evaluating the clinical areas experience and how useful they find having them. And we are working up a proposal for how we could effectively onboard these chaps when GMC make it easier to register and license doctors, which became a lot harder during the pandemic because they suspended a lot of the PLAB testing, for example, and then give them a route to join the medical workforce. So in a short, David, there isn't a HEAM plan, but we're working one up for ourselves.
Thank you.
Okay, thank you. We'll take Denise and then just a quick check, and then Simon, and then we'll move on to the other two directors.
Okay, thanks, Alan. I just wanted to ask for any comment on the maternity C-section rates, which has been consistently over target, and I've not seen any action on it. So I just wanted to sort of pick up on that and see where we were at with that, please.
You want to answer that quickly, Somebody? No. Okay, well, I'll give you a chance later on. Simon.
Thanks. Just wanted to draw the board's attention to the new bundle of 10 A&E standards that have been published, and we will be expected to, and we will be monitored against going forward. I'd commend, I think, to the Quality Committee a review of how we are doing against those standards in June and July. So by the time we come back to public board, I'd like us to be in a position where we could have a discussion about those, because back to your question, Anne, they point to a wider consideration of how patients are experiencing our urgent emergency care system than just a simple 4-hour metric. And I think we would do well in our July board to reflect on the lessons that our initial observations around those standards are telling us, and what that might mean we might ask of our partners, what that might mean we need to do differently ourselves. Thank you, that was it.
Okay, I guess Tom's comment is coming back to Denise. Tom?
Yeah, yes, thank you, Chair. And just to reassure Denise and my co-NED on the Quality Governance Committee may wish to come in, because she also speaks from professional experience, but maternity services forms now a significant component of the quality governance agenda, in particular with us having to review the response to the Ockenden report, and also this month we had a report on the CNST and our performance against those criteria. So I think, Denise, just to reassure you that we have a very thorough review of a presentation by the Deputy Director of Midwifery, who's supporting Sharon in making sure that those issues are challenged, and where necessary support is given.
Okay.
Jill may want to add some more technical response to that.
Thank you for that. I think we know that maternity services will be a focus, or we would expect that to be a focus of the CQC around both the Ockenden and SIs in general. We have focus to bring to that problem. Jill.
Thank you, Chair, and thank you, Tom. Just to answer Denise's very specific question, yes, this has been subject to our monthly maternity and neonatal champion meetings, Denise, because we have been noting that it's not only being raised for some time, but the figure hasn't been changing. So the team have done an extensive case note audit and found very little changes that they could make. The problem with caesarean sections, there's some nice guidance that allows women to choose to have a caesarean section. We offer them counselling and support, particularly if they've had a previous caesarean section and aren't keen to have a vaginal birth. But at the end of the day, if they decide to go ahead, then we support them to do that. And then, of course, the other group of women are those that need clinical caesarean sections for clinical reasons. And we certainly wouldn't want to reduce them. So there's been quite a lot of focus and continues to be so. But to add to that, at the local maternity and neonatal system board, they have decided to remove caesarean sections from their dashboard as a target, so to speak, because they are undertaken for clinical reasons and through patient choice. So there isn't a magic number that is right or wrong. Nationally, they're all heading in the upward direction, and we will do absolutely all we can to try and minimise that, because at the end of the day, of course, it is a surgical procedure. And we will continue to monitor it, but we will take it off the RAG rating, if you like, and just look at it from a clinical perspective. So I hope that answers the question.
Okay, I think that's a pretty thorough answer. I'm going to move on. I see a hand up. I'm going to move on because I'm very conscious of time on this one. So Mark, who will also be conscious of time.
Thank you, Ellen. Always conscious of time. So I will be brief, and I'll take the report as read. I just wanted to bring to the board's attention a number of things that we discussed at our first formal people committee in common on Monday, in fact. So There are a number of areas that you would expect us to discuss, which we went through in terms of predominantly focused in relation to medical education, nurse education, nurse training and medical training and numbers as well. The couple of highlights that I just put, or the highlights, positives, negatives, whichever we want to describe it, that I'll pull out from my particular report, is that in the people plan that we have approved at the board on the 31st of March, or the end of March, we have started to progress a number of actions around this. So we do have this very week, our first ever joint leadership programs have started across both Kettering and Northampton. So that's really positive to watch our colleagues undertake and receive development in conjunction with one another as we work on our journey of collaboration. I'm very, very pleased about that. The second element that I'd like to point out to the board's attention is in regards to employee relations. So how we manage our employee relations cases. And I have to say, we've been found wanting across both hospitals in some cases that I have seen recently in relation to this. And we're very much now looking at the Dame Dido Harding review. We did that in 2019, but we're very much looking at it once more to make sure we accurately reflect how we want people to be treated in our organisations in both of our hospitals, should they be subject to disciplinary processes and so on and so forth. We will be doing that in a further workshop in June as part of the Joint People Committee development. And I aim to bring that back here for our discussion in public in July to demonstrate the work that we have undertaken in amending our processes and indeed our policies to make sure that we can have conversations with one another and we can treat each other in a fair and just culture type approach way. So they're the really important elements that I wanted to point out. Of course, they are metrics that everybody can read in relation to vacancy and turnover positions. I know Bola's going to talk very soon about agency, so why would I not talk about that now? And we'll probably talk about it again in the operational item next too, so I don't want to go on about it too much, but it is a really important area of focus for us. As you can see, it's an area where we have overspent in month one, and we need to make sure we address that situation based on the additional posts that we're putting into the system too, but I'll perhaps pick that up under the planning submission under our next agenda item. And the final thing to bring to everybody's attention is across the system, we're doing a number of activities and work across the system in relation to health and wellbeing, and our second ever virtual health and wellbeing festival will take place in June, and our events and dates and diary times for that. We have another whole bunch of celebrities that are joining us on that, but also that agenda is filled with a number of our own colleagues talking about their current experiences and sharing any learning that they have. Other than that, I'm happy to take any comments. Thank you.
Okay, thank you. I'm going to move straight on to Bola, and any comments we'll pick up at the end. Bola.
Thank you, Chair. First, I just wanted to, I'll talk about month one, but just conscious that we haven't reported back formally on month 12. Just wanted to report back to the board that the trust performed better than our forecast plan, and we reported a surplus of 303,000 at the end of 2021. The external audit work is ongoing and the final accounts are due to be finalized by the end of June. I would also like to place on record my thanks to the finance team for all their hard work in getting us to this position. Now, moving swiftly on to month one, I'm again pleased to report the month one financial position of 949,000 surplus against a draft plan, which means a draft plan of 903,000, which means we're better by 46,000. I mean, obviously the draft plan is on the agenda for discussion shortly. Just a couple of points I would like to highlight, please. As my colleagues have already said, we've seen an increase in activity, both in ED and elective care as well, which is obviously good for our patients. And as we are on block contract for Health One at least, it gives us an opportunity to focus, on the cost areas. Mark has already touched on, the fact that we were overspent in month one by 328,000 because of pay and largely because of agency. Although we were overspent by pay, we underspent on non-pay, which helped to offset, that overspend. Therefore, it means as activity starts to increase, non-pay is likely to rise. Therefore, we need to focus and act very quickly on our agency spend, obviously ensuring that we continue to protect and provide excellent quality of care to our patients, and also looking after our staff. But in aspects where there are, things that we can do, then we must focus on that in terms of agency spend in particular. exploring opportunities for alternative forms of contracting, rate negotiation, etc. And I'm sure Mark will talk to that in a bit more detail. Having said that, agency spend in month 1 was 1.5 million, which was $500,000 better than the previous month. So it shows a movement in the right direction, but we need to do better. We need to do more. And lastly, I just wanted to say that the capital plan for the year, which is presented in the next agenda item for approval by the board, is 18.9 million. In terms of month 1, our spend against this was 1.5 million. With a further commitment of 7.1 million, which is good, but we must ensure that we deliver on our capital plan this year. Thank you, and I'll take any questions.
Okay, thank you. Hands, let me see. Yeah, Anne first. I think is the only hand up. Anne.
Yes, thank you. Yeah, on agency spend, we've got an enormous target to hit, and I wondered, in terms of the drivers of agency spend, I know sickness, absence, for example, is one of them, and maybe turnover. But do we know if the investment in health and well-being is actually having a positive impact on reducing absence, sickness absence? That was one question. And in terms of our workforce plan, does that help to address some of the, in terms of why we need agency spend? So I guess my question is, the drivers of agency spend, how confident are we that some of the things that we're doing, like health and well-being, which absolutely we should be doing and looking after our staff, but is that having a positive impact on reducing the need for agency and improving sickness absence or attendance rates?
Okay, I don't see any other hands up, so let's answer that question and then we'll move to the break. Mark.
Thank you, Alan. Thank you, Anne, for the question. So in terms of our absence position, we have seen a reduction in our absence position as we come out of winter. And I think based on the intelligence that we understand from our colleagues, the position could have been, well, I know certainly it could have been worse had we not have put the health and wellbeing initiatives in place that we have had, such as our SOS team, etc. So I'm grateful for that. And of course, a higher absence would result in higher agency spend. So I'm very pleased that we're avoiding some. There is still work to do in terms of managing absence in the organisation and supporting people to come back to work. And we know our biggest areas and drivers around this at the moment is no longer COVID. It's now back into musculoskeletal and stress and anxiety issues. And of course, some of that is impacted by COVID in terms of some of the anxiety situations. So and indeed long COVID that we're now tackling as well. So we're tackling the absence management. Our predominant driver in relation to our agency spend is our vacancy position. So that is the piece of work that we are so heavily focused upon. And as you can see by some of the articulation in the graphs, some of that centers around our medical, but also some of our nursing positions. We have a plan in relation to recruiting positions, and we believe that to be robust, and we have a plan across the system. That has not, however, been borne out in month 1, which is why, in addition to the plans, we need to monitor the plans, and monitoring of those plans is going to be taken forward at the SLT meeting on Tuesday, and Bronwyn's going to take that forward in terms of how can we keep an eye on, or keep an eye on is perhaps too glib a phrase, but how can we manage our agency's position particularly. So that includes things such as obviously recruitment, but also those dialogues and conversations with agency workers in terms of alternative rates and so on and so forth. So we are absolutely on it. As Bola said, it's £500,000 less than March, so that's good. It's not at the levels that we need it to be, and we know that, and we're going to continue to work on driving that position down.
Just on that point, the board were reassured about 14 months ago, before COVID hit, that there would be a senior group reviewing bank and agency staff meeting on a weekly basis. I think it involved yourself and presumably the medical and nursing director and whatever. Can you just reassure the board that that is still happening, that we still have a very tight senior managerial grip on the use of agency staff?
That's exactly the meeting that I'm talking about reinvigorating, Alan. So we closed that down over the winter because we had other pressures to deal with, but that is exactly the meeting that we're looking to re-establish now. That's exactly my point.
Okay, good. Thank you very much. I don't see any other hands up. So we'll move to the agenda break now, back at 11:05, please. 11:05, thank you.
She has. She's currently plugged into like LAN, but it's turned. Wi-Fi's turned off.
Hi, Polly.
Okay, thank you for that. We're at 11:05. Item 10, 2021-22 planning. Welcome to Polly, Director of Strategy at KGH, who's going to talk in particular about elective recovery, for which she leads as a system. Karen is going to orchestrate this process when significant contributions from Bola, Mark and Joe on finance, people and activity. And in the end of the day, this final plan for the first half of this year, you might hear people talking about H1, that's the first half of this year, will become part of the system plan, which goes in on the 3rd of June. So, yeah, okay. So, we've talked about this before being the best we can achieve, and the question about balance between workforce and people, elective recovery and finance, and does it all match? So I'm sure the board will have some questions for people, but the principal one in the end is, have we got the balance right? Is there anything contradictory in this plan? Is there anything that just does not hang together? The people and the finance, for instance, or the finance and the activity, whatever it is. But we need to look carefully at this and decide if we have indeed got the balance right. Over to you, Karen.
Thank you, Chair.
Thank you, Kieran. I just want to go to the next slide. We've just got one slide, then I'll hand over to colleagues. But this slide just articulates that point about the balancing the three drivers. But I just want to start by saying that this paper presents our group final plans for the first 6 months of the year. We recognise that they were only being asked to submit for the first 6 months, and we're expecting additional guidance, as Simon's talked about, for the second half of the year. This plan will be incorporated into the system plan submission, which is due next week. So we're asked to sign this off today. And I think what we need to really focus on, as has been articulated and raised already, is just really picking up and keeping in our minds the story, our patient's story around, have we got this right in our plan? And have we got the balance right between these three key drivers? So we'll be talking about our patients, getting it right for our patients, our staff, make sure we have the workforce in place, and also looking after our staff, the health and well-being of our staff, and also money in terms of have we got the costs, looking at our costs. So I shall hand over to colleagues to take you through each in turn. So Polly will start, and then we'll talk about activity over to Joe, and then we'll go on to the workforce with Mark, and Bola will finish with the finance. There'll be opportunity at the end of each to have questions. But I suppose, as we've already talked about, the real sort of question is, are we being sufficiently ambitious for our patients whilst recognising we need to be realistic as well? I won't say any more at this stage. Kieran, you can take that slide down, and we'll hand over, start off with Polly. Thank you.
Thank you, Karen, and thank you for welcoming me. So Polly Grimmett, Director of Strategy over at Kettering, but the System Elective Care Lead for Northamptonshire, as you said, Chair. So, and I think the elective recovery in general is a really good example of those three circles that Karen just spoke about. The system financial plan and the group financial plan is for break even, but that is reliant, as I'm sure Bola will talk about in a moment, on our elective recovery, because nationally there is a fund called the Elective Recovery Fund, the ERF, that basically incentivises through additional money, incentivises elective recovery, so reducing the waiting list and getting back to the same kind of elective performance as hospitals were pre-COVID. Obviously, the board will be aware that there are some very long waiting lists that have built up across the NHS because of the impact of COVID, and we need to try and reduce those, get access for our patients into the procedures that they need. The elective recovery is very important for the financial plan, but of course, one of the key risks and the things we really need to make sure that we protect is the health and well-being of our staff. Our theatre staff across the acute sector had a vital role to play in COVID because many of them moved into supporting intensive care activity and the COVID patients that were in there. So they've worked really hard all year throughout the pandemic, and now we're asking them to return back and start to continue to work really hard on recovering our patient waiting times. And that's really difficult. So that's one of the key risks really to the elective recovery is the health and well-being of our staff and making sure we're protecting them. But I'll just say a few words as to where we are. So the Elective Recovery Fund, just to make it clear, is allocated at system performance level. So there is a real incentive for providers across the county to work together to maximise the capacity and to make sure that our waiting times and our delivery is consistent across the county. Because if we have Northampton, for example, Northampton Hospital really performing well on their elective recovery and Kettering not performing well, then as a system, none of us will get access to the Elective Recovery Fund. So some real incentives to work at system level here. And as a system, our final submission is an improvement to the draft submission that we submitted back at the beginning of May. So we are predicting higher levels of elective activity in this submission than we were thinking. And partly that's because we have opened up additional capacity. We've been able to safely open up some of our elective theatres at Kettering and at Northampton. So what you'll also see in our submission is a general improvement every month. So as we start to get towards, as Karen said, it's a 6-month plan. So as we start to get towards July, August, September, our elective activity rates are increasing month on month. And we do expect to hit the ERF thresholds. The ERF thresholds get up to 85% of pre-COVID levels by August and September, and we are expecting to hit that. But there are some risks. The three key risks really, as one I've already talked about, is making sure our staff are protected and the health and well-being of those. The independent sector. So as a county, we are big users of the independent sector. They help support NHS work quite a lot. And we need to make sure that we're maximising and continuing to work closely with our independent sector partners to continue for them to help us support us with our NHS waiting lists. And of course, elective beds as well. So one of the key risks is that if our non-elective performance or activity goes up and patients continue to get admitted and accessing our A&E, then that might put at risk our ability to protect our elective beds. Those are the key risks. But in terms of opportunities, so there are opportunities. There is more capacity in the independent sector than other counties have. As I say, we need to, whilst it's a risk, it's also a great opportunity to do even better than we're doing now. We do have some capacity still in the system that isn't as yet factored into these plans. So we are currently working really closely with the two chief operating officers, and I'll hand over to Joe in a moment, about how we maximise the use of that capacity to enable us to put even more activity through. One of the key things we're working across the system is on a shared PTL. So that's a patient tracking list. So it's a waiting list, basically. Traditionally, organisations have their own waiting lists, and we treat patients at an organisational level. And what we're working on, and our Chief Digital Information Officer, Andy, is working on getting a shared waiting list across the county. And what that will enable us to do is to make the best use of capacity across the system, so that every patient in the county has the same waiting times, regardless of which provider that they're going to get treated in. And that's really going to help us. And it's also really going to help our GP colleagues to make sure that they can see where the waiting list problems are, and they can refer patients to make sure they get seen quicker elsewhere. And they can also help to support some of those patients in primary care while those patients are still on a waiting list for treatment. They'll be able to know how long that waiting list is, and therefore what they need to continue to do in primary care to support those patients keeping well for longer. The other key thing as an opportunity is GERFT, so getting it right first time. It's a national programme of efficiencies. So we are working across the system now at system level, including our primary care colleagues, on what our opportunities are in that to manage demand. And as I say, to help try and keep patients well for longer in their communities and in their homes. So that's our approach at a system level. We have a system elective care board set up that includes partners from across the system, and we're working on some of those initiatives at some pace in that group. But I will hand, I think, over to Jo now to have NGH perspective on the work that she's doing.
Thank you, Polly. Just a couple of points from me, just building on what you have said. So in putting together our plan, we've been cognizant of the risks that Polly has outlined. Firstly, around resilience and availability of theatre staff. We have had a focused reset week with our theatre staff. We continue to support our theatre staff, but they do not want to work extra lists and extra weekends currently, but we're continuing those conversations. So we have to be realistic about that, and we have to support our staff in what they want to do currently. In terms of elective beds, you've heard about the Discharge and Flow programme. I will not go into that, but we are right-sizing our capacity for surgery and for medicine so that we can protect our elective throughput each week. And you've heard that orthopaedics will start next week, and our intention is to continue that right throughout the winter if we can do. And you've heard from me today that our DSU, our day surgery unit, will be fully functioning and will be supporting our elective programme. All our theatres will be back up and running, and we intend to keep it that way. I feel assured that we can keep that going. We'll be maximising our capacity. We will have weekly performance meetings where I will be with the divisions. We have confirmed and challenged all of this position with the divisions over the last few weeks. It's been a really rigorous process, and we've talked in particular about how we keep the activity going during the summertime, when we know our staff will definitely want a holiday, and of course they should have a holiday, and we need to make sure that happens. So divisions are currently working on the summer plans, and they will be bringing that back through the weekly meetings. And Carl, my deputy, will also be looking at performance on a daily aspect as well, ensuring that we're hitting the targets that we should be hitting and we're getting the throughput that we should be getting. So we have got in place things to support this as we go through. There are further opportunities, as Polly has said. We know there is some theatre capacity at Kettering that we can utilise, but of course that is dependent on me sending staff, which is clearly a difficult thing for me to do at the minute, but we're looking at it. We have identified specialties that can send patients to the private sector, as Polly has said. So we're working on the plan to do that. And we know that we have got productivity opportunities, but I don't know what they fully are at this moment in time. So are we being ambitious? I think we are being ambitious as to where we are now with our staff. We are talking to our staff, we are supporting our staff, but we have to be realistic. And this plan is based on what we realistically can achieve at this point in time. Our staff are behind it, they've signed up to it, and they're already doing it. So I think for me and the teams, we will work tirelessly to do this and see what other capacity we can put in place. We have assumed weekend activity as well, and that's through the insourcing company who are totally signed up to working with us, and that will continue. But I will be trying to put on extra capacity where I can, but I feel it's realistic at the moment. I'll now hand over to Mark.
Joe. So I was just going to go through the submission that we made to the People Committee on Monday and talk a little bit in terms of our overall position. So the workforce submission for the system was articulated and has been completed in line with the national and of course our group people plan. So the predominant focus of that system response is in regards to, as I've already discussed this morning on a number of occasions, our health and wellbeing as of colleagues, of our staff and how we ensure that during the reset and recovery we're looking after the people that look after the people, if that makes sense, and making sure that we are ensuring that they have the best opportunity to health and wellbeing activities and interventions. There's also a lot of other work that I could talk about for a long time in terms of the system that we're working through in terms of equality, diversity and inclusion, which we know is a real big issue for us in our hospital, but also indeed across the system we can take some good learning and practice. The system response also discusses new ways of working. We already heard today around the new role in terms of medical support worker that's being brought into our hospital and indeed across the system, how we look at the new roles that we can introduce in the short term, but also what we are planning for our higher education authorities as we move into the more medium to longer term planning. What roles will we need in the future? Is it more of the same or will they be slightly different? I would suggest we're going to be more in the latter than the former. And then there is what do we do in the short term in relation to some of our gaps around international nurse recruitment, and I'll come on to that in our planning submission in a second. So going down to the real detail, if you like, across the group and indeed both Acute's planning submission. So we plan to increase our workforce over the two hospitals by over 500 whole-time equivalents as part of this planning submission. Now that sounds quite scary. It did sound quite scary when I first heard it, and it sounds quite scary when you say it like that. But it's important to be said that this is not necessarily just physical posts. This is also pay into posts. So as Joe's articulated, we will be looking to conduct additional activity and additional lists, and that attracts an ADH payment as it stands, or a WLI payment, which is a waiting list initiative payment for colleagues to undertake those pieces of work. And so that can be articulated and attributed back into whole-time equivalents. What's important around the whole-time equivalent increases as part of this plan is to stress test this in terms of how much of this workforce is feasible, what's our confidence levels in terms of recruiting this level of workforce and where from, and how much do we need and when in terms of when we phase our additional workforce through the course of this year. And I'm pleased to say we undertook that piece of work and we concluded that piece of work yesterday evening as part of the system. Bola and Karen attended on behalf of the Trust along with myself to work through exactly that, having looked at every single post in detail against a specific set of criteria. Are we assured that we have the ability to recruit into these positions and that we can do that during the course of this year? And that's really important because that plays to this statement just before we finished for our break earlier this morning in relation to our agency spend position. And you can see where the nervousness will occur in increasing and putting these additional posts in place. If we do not recruit to them substantively, then there is the attraction or the possibility of us temporarily recruiting into them via agency, which would have a total counterbalance in terms of our planning submission from a financial perspective. So we are keeping a very, very close watchful eye on that position and making sure we can bring colleagues in to those posts. Of the posts, it's a very valid question you may wish to ask in terms of where a number of those posts centre and sit. A number of them sit in the healthcare support workforce, and we have done great guns in the last 6 months in recruiting into lots and lots of those positions in both Kettering and Northampton, which is fantastic. And that was also something that was called out at our regulatory review meeting last week in terms of that closing that gap from high vacancy to low. We also, and something that we've done really well here in NGH is our nurse vacancy, and obviously it's a testament to Sharon. I'm just trying to find where you are on my screen, and the team in terms of the international nurse recruitment work that's been undertaken already last year. And we have a number of nurse vacancies in this year's plan too. And international nurse recruitment is one of our risks in terms of this particular plan. So we know, and so far to date, touch wood, everything has gone absolutely to plan in relation to the colleagues that we were expecting from overseas. But we know, based on the impact that COVID-19 is having across the world, that this may change and has indeed changed in one country in particular, namely in India. And we'll continue to look and reprofile that international recruitment as we go through the course of the year. So that leads me on to the risks, of which international nurse recruitment is obviously one, and recruitment in general into some of the posts that are not just nursing and healthcare support worker posts, but we, based on the stress test process that we undertook across the system, we have confidence in delivering against that activity. But recruitment is obviously a key element. Absence, as we've talked about, sickness absence is a second risk around this. If we, it feels that if we push people a bit too hard, too fast, then we may see an increase in our sickness absence position, and that correspondingly will lead to temporary staffing requirements in order to maintain patient care and safety. So that's why, and as Joe's articulated as Polly, it's a very important fine balance and tread for us to go on this particular plan. But we believe, based on what we have submitted to date, it's realistic and indeed achievable. The last and final risk in our plan is in relation to retention. So just to bring to the board's attention that we are looking at retention. We've done very well over this in the last 18 months in terms of our overall trust position. But we know, again, given the circumstances that people have worked through in the recent past, we have a workforce across the region and indeed in our own hospitals who may well be reaching retirement age in the near future, and we need to help and support them and obviously encourage them to retain and stay in the workforce as opposed to retiring. And we're just conducting that analysis across our system at the moment. It's not a huge concern for us at the moment, given the numbers of people and the age that we've seen, but it's something for us to be mindful of, and indeed retention in the more general terms. But I will close there and hand over to Bola.
Thank you very much, Mark. So just referencing earlier comments my colleagues have made, the key challenge for us this year will be how we balance the activity, how we balance that against looking after our staff, and of course the money. In terms of the H1, the health one, April to September financial plan, I can confirm that it triangulates largely with the workforce and activity plans. However, what I would like to flag is that there's something about the timing of the returns. So we did the first draft of the workforce, activity, and the money, and that triangulates. However, the system is requiring that we do a final submission for activity and workforce, but not for the money. And as colleagues have already pointed out, there will be additional costs, due to additional diagnostics using the independent sector, and also just generally by improving our activity, which is not currently factored in the current plan. The other assumptions we've made in the H1 plan assumes delivery of activity, as I said, based on current baseline capacity and workforce. And we haven't assumed any increase, any potential impact of a third wave of COVID. Other assumptions include ERF, which Polly has already mentioned, the Elective Recovery Fund, 3.8 million for NGH and 6.6 million across the group. We've got an agency target, which Mark has referenced all morning, of 7.3 million in half one, and we now need to make concerted efforts to make sure that that is a reality. We've also got our efficiency target of 10.9 million for the full year and 6 million for half one. We've been working, it's also important to say that for half one, the plan that we submit is a break-even plan, which meets NHSEI's expectations. And it supports the view across the country, actually. We've been working with system partners to develop a full year view, which currently stands at a deficit of 117 million, of which the group deficit is 107 million, almost split equally across NGH and KGH. The key drivers, as you would expect, is pay and WC increases, hence the real push to make sure that we get this right in terms of our staffing levels and the productivity from that. And of course, still balancing that against the health and well-being of our staff, looking after our staff. The other area I'll just like to bring to the board's attention, as I referenced earlier, is the capital plan allocation for NGH for the year is 18.9 million. So as a system, NHSEI this year are allocating our capital plan by system. So the capital plan allocation for Northamptonshire was 40.5 million, and we agreed with system partners on a fair shares basis. Our share of that is 18.9 million. We're taking that through Capital Committee, the Finance Performance Committee, and happy to present to board for approval. In terms of the risks, as colleagues have already highlighted, we've got risks, the workforce availability to deliver this plan, risks around a potential third wave of COVID, risks around the ERF achievement because that is system delivery, and also, of course, the additional costs that we may incur in delivering the activity. In terms of next steps and what we need to do, we need to develop a clear financial strategy that aims to balance the competing needs of patients, people, and the money. And as Mark has already said, we'll be reinstating the workforce management meetings, to support the recruitment drive so that we can apply some rigor across agency usage. We also need to develop robust efficiency schemes. To date, across the group, we've identified 14.2 million of the full CIP targets, which is about 77%. But that includes recurrent and non-recurrent CIP schemes. We now need to focus on delivery and also see how we can turn some of those non-recurrent schemes, which is probably about 50-50 at the moment, to recurrent schemes. So a fair challenge, for this financial year. And I'll stop there, and we'll be happy to take any questions. And also, just to reiterate that we would like the board to consider the recommendations for approval of the H1 plan. Thank you.
Thank you.
Okay.
Thank you.
Go on, Karen.
No, sorry, I was just going to say thank you, colleagues, and thank you, Bola. And just to say that we've had an opportunity now to hear from each of the leads on each of those areas and how they obviously are all working together and how we're balancing those priorities. And we wanted to really now have an opportunity for a discussion across the board around our ambition and if we've got this right for our patients. Thank you.
Okay, thank you for that. Jill and then Anne, please.
Thank you, Chair, and thank you, colleagues, for such a comprehensive presentation. So I've been fortunate enough to have been in Quality Governance Committee last week and Finance and Performance yesterday, and can confirm that we had extremely robust discussions about how we balance out these three circles. I think potentially this has been one of the most difficult plans that we've ever had to do, because it's such a fine art. We have, I think, articulated the risks very well in the paper, as well as the positive outcomes and what we hope to achieve. Because if any of those risks do come into play, then of course we will not achieve the outcomes that we're aiming for. A couple of questions, if I may. I absolutely support the paper. But one of the things I wanted to ask Mark was, I've been keeping an eye on what comes out of the Royal Colleges, because people were predicting that an awful lot of clinical staff would take early retirement after the year they've just had. And what I'm seeing from surveys is that this isn't the case, which is quite reassuring. But I just wondered from our staff perspective whether we're seeing any of that. And then secondly, from patients like John's perspective, and I know this is happening, but could probably do with a little bit more information about how we're clinically prioritising the patients.
Okay, can we just gather some questions? Oh, you're frozen, Joe. I'm hoping you're finished. Can we just keep going? Anne and then Denise. Anne, you're still muted.
Sorry. Yeah, difficult balance to strike. So I appreciate the work that's gone into this plan. I think my concern is how we break the cycle, because if you take, for example, theatres where staff are having to do extra sessions, then that triggers possibly, increase in sickness absence. There's also patient risk. So it's, how can we break that cycle? And also agile working, Mark, I know you got that in under health and wellbeing. I wonder what opportunities that creates, A, to position us very competitively in the marketplace, but B, to kind of maybe give some hope to staff that it's not just all about working long extra hours, but there maybe is a different way of working. And I didn't know what feedback we'd had from staff recently on what else they feel would help them through to what they've got to deliver. Thanks.
Denise.
Thanks, Alan. I just wanted to pick up, and this links back to the previous discussion we were having around the agency staff spend. So a lot of the focus, quite rightly, when we're looking at new ways of working, have been on the clinical side of things, the sort of patient-facing side of things, if you like, and just sort of looking for some reassurance in all of the discussions that have taken place that we're also robustly looking at both agency spend and new ways of working in the non-patient facing parts of the hospital. Thank you.
Okay, final comment. I'll go to, on this section, this little bit. Anyway, Stuart, and then I'll come back to the presenters to think about responding. Stuart.
Yeah, thanks, Chair. Just really to chip in on the question about agile working, as posed to Mark, just a couple of examples. So we're working with our cancer services team at the moment and trialling some agile working space. So rather than setting up big committees and trying to fix the whole trust for agile working, we are working with those guys and we're going to set up an example of what that could look like. So hot desking, such like. So I can bring more detail back, but that's ongoing. And then the second piece, the transformation team led by Ruth Smith were working on a piece around virtual clinics. And again, why run virtual clinics from treatment rooms? So again, we said from the estates pot, we would fund that piece of work and see if we can set up a sort of virtual clinic area that would reduce the need for clinic space. So Mark can add more about agile working, but there is stuff going on to test these theories and do a bit of a sort of feasibility work.
Okay, thank you for that. I think most of the comments are directed at workforce, Mark, but happy for Karen to orchestrate if it requires more. Mark.
Okay, thank you. You can hand over to me, Karen. I can take them all. So, but thank you, Stuart, for coming in on agile working, stealing my cancer scenario. But there is a, as Stuart said, in terms of agile working, there are trials that we undertake, and we acknowledge that what we did before is not what was going to be acceptable moving forward. People's expectations have changed in the workplace now, and what they want from work is definitely changing. So we need to look at that in terms of how we are more agile. However, that being said, a lot of the work that we need to undertake is physical treatment of patients in a physical location. So that is a challenge because we physically need to be here in order to do that. The remoteness of that is more tricky, but as you can hear in terms of virtual clinics and so on and so forth, we're definitely looking at every possible opportunity to maximise that and to make it exciting to come and work here in Northampton and indeed Kettering. The piece that I just like to pick up on retirement, Anne, is in relation to sorry to Jill, we have looked at that in terms of our position, and at the moment we are basing our assumptions on what people are telling us, which is, you're right, that people aren't expecting to leave dramatically for any time soon, but we're also looking at the age profile. But we also know from the research that we're getting out in terms of the psychological impact of COVID for our SOS teams, etc., is that we may not see this initially. It might be as the months progress, or indeed the really important factor that's coming out at the moment is this huge anxiety around if this happens again this winter. So I've just gone through the winter that I have gone through, can I face another one? So if we start to see that curve that we all get to see nationally now and we've all sort of become accustomed to, if that starts to climb again, that's where we're going to really need to wrap our arms around our colleagues and make sure that they know we are here for them, because it's that I'm not sure I can face what I have just faced again in such a short space of time. So we're hearing that as part of our SOS conversations, and then that's a thing that's up there. It's something that's sort of down the track because it hasn't come into fruition yet, and hopefully it never does. But that's something that we have to just keep an eye on in terms of, particularly in relation to people deciding to leave the organisation or indeed retire. In picking up the non-patient facing agency spend position, we are absolutely looking at that, Denise. But there is also something about investing in that infrastructure. So you would have seen in the agency spend report a number of those agency spend positions, if you like, at month 12 and month 1 are in relation to our digital services, because we are enhancing our digital services and indeed looking to change our EPR. So we are looking at it, yes, but we are realistic also about what we're trying to put additional resources in order to make the future better. But we acknowledge that we need to live within our means and therefore within the plan that we've submitted, because that's our plan, and we need to deliver upon our plan. And I suppose finally, the last part about what would help staff. And I think this is where we as a board and indeed as leaders across the organisations play a really important point. The bit that we understand that staff want the most at the moment is clarity. So clarity on expectations. So what is it you are asking us to do, and what are the priorities that you are asking us to focus on? So it doesn't feel that we're confused. I think we've all lived in the world of uncertainty for the last 12, 15 months. And what our staff are really craving at the moment is that certainty. Now, there's one thing in life we can never do. There's only two things in life that are always certain, and I won't go into that. But there's a situation where we have to try and create as much certainty as we can by articulating what our priorities are and sticking by them, in terms of elective recovery being an example of that, and so on and so forth. We need to be clear with people, this is what we're expecting of them, because that is what causes the concern in terms of, so much has been uncertain. I'm not sure how much more uncertainty I can cope with. We need to be able to provide clarity. This is what we are focusing our attentions on, whether it be between now and the end of half 1, or whether it be between now and the winter, or so on and so forth. That is what people are asking from us. And I think that's what they deserve.
Okay, thank you. I haven't got any more. Wait a minute, things are flickering. Right, Stuart, your hand is still up. I presume that's a historic hand. David.
Yeah, thank you, Alan. I just emphasise the point that Bowler was making about transformation. Actually, transformation is absolutely key to the delivery of the not only H1, but it will be key to the delivery of H2 as well. And in finance and performance, we did talk about transformation. We did talk about productivity, theatre productivity, consultant productivity. And this is not just a discussion about cost saving. This is a discussion about positively impacting outcomes to patients. So I'd just like to reiterate the performance of making sure that our transformation programs are absolutely state of the art. Thank you, Chair.
Thank you. Simon.
Thanks, Alan. Thanks to everybody who's presented this morning. I've referred already, I think, to the QSRM letter, the Quarterly System Review Meeting letter, which we received, the feedback of which we received last evening. And I think it's important that the board's aware of the points that were made in that letter to us. They frame, if you like, our regulators' assessment of where we are in our journey to date. Main point on elective recovery. In our first submission, we were low nationally. And so I'd like Polly just to talk and just reassure the board that our revised submission will now take us into an area where we would be judged, and most importantly of all, of delivering for our patients in actual fact, but our assessment against our peers would be regarded as at least as good as and potentially better. So there's a question there around just absolute levels of activity. The related questions that we got asked on elective were, and you touched on it, Polly, but the faster we get to a system PTL and our ability to track the activity that is going through our system, because as we all know, it's not going to be simply possible for people to be referred into us and just sit on waiting lists. We're going to have to work together. Elective recovery is going to require a whole system effort. So I'm interested in your comments on a system PTL and when we will deliver that. Thirdly, we were asked whether we were going to submit a community diagnostic hub. bid. We haven't done yet, and clearly any additional capacity given the expected bounce back that we need will be really important. So those three on elective recovery. On workforce, I should start by saying we were commended as one of the best systems in the region in terms of supporting our staff. There was unambiguous feedback in the letter, and I will make the letter available after this meeting to all board members so you can see it and reflect on it for yourself. But unqualified approval for the work that we've done. The key challenge, and I just want Mark to reflect on it, I suppose, would be we've got a pretty ambitious bank and agency reduction plan. And I think within that, there's a nursing angle to this, because when I spoke to the regional chief nurse recently, she said, you know, we might even be looking to expand our bank, because if people are, as colleagues have commented, looking to take time out, you'd want to keep them on your bank, keep them in your organisational family, rather than just seeing them disappear. So comments on that, I think, would be particularly helpful. I think there's a question that the board needs to think about in terms of what does this deliver for patients? So at the end of half one, where do we think we will be? There's lots we don't know about it. Bounce back is the biggest factor in that in terms of activity. But Joe, you know, where do you think we'll be on 52-week waits at the end of the period? Would be a good question to start with. And where do you think we'll be on cancer delivery, which would be the other key metric against which will be assessed? And lastly, I don't really want to make too much more of half two, but David's point, I think, is a really good one. So as a system, the commentary that you will see is that we urgently need to work together to develop a half two and beyond plan. So we have a good shout, if we do the things that we say we will, of getting through half one and hitting our marks at the end of that period. I don't think we can be anywhere near as confident about half two. I'm leaving aside the kind of COVID winter assumptions. I think those are yet to be determined. I'm thinking more about the underlying financials of the system and the need for a completely different approach in terms of developing an approach to that, which I think is much more of a system conversation. And I would be proposing we have a first crack at with our new CFO, who joins us in the next couple of weeks. So those three questions, I just think the board should hear. We are in public on those points. So I'd like to go to Polly, then Mark, then Joe, if I could.
Thank you very much, Simon. So yes, more than happy to answer on those few related points. So in terms of the actual activity submission, the improvement, as I stated, there is an improvement from the draft plan that we submitted earlier in May and the one that we will be submitting as a system. In terms of the actual specifics of that improvement, so for example, we have used month one actuals, and in month one, Northampton improved by 4% on their plan. So they delivered more activity than you'd been anticipating to do, which is brilliant. And from a Kettering perspective, we've added in another 3,000 cases into our plan because our theatres got signed off as being safe from infection control to be able to open more theatres. So those are some actual improvement numbers that will be included in this submission. I think it's also relevant to say we were also praised in the QSRN that Simon's referring to for some of our elective waiting times. So whilst our performance in terms of where we were compared to what we were doing in 2019 was a little low in our first draft submission, as I say, that will improve in our final draft. We were praised for our elective waiting times to the extent that it was commented that would we be able to help out other systems who are unable to recover their waiting times as quickly as we are setting out that we'll do. So that was a positive. In terms of the second point that you raised, Simon, which was about the shared PTL, can I give board assurance on a specific date where we think that will be in place? Unfortunately, I can't do that at the moment. But what I can say is it's an absolute system priority of the elective care group, and Andy is leading that piece of work with me. We have The approach that we took initially was to see how we could bring together the organisation's waiting lists. However, what we found is that's a nigh on impossible task just because of the way they're set out and the data capture. So what Andy has found is some bespoke systems that will enable us to pull the waiting lists together and present a system approach. We're at the point where we've got a couple of those, so we are doing some roadshows and some testing of those over the next few weeks, and we'll then be at a point to be able to confirm that we found one that will be able to deliver what we need it to deliver, and get system sign-off and agreement to putting that in place. I have no doubt that we will get system sign-off when the time is right. I don't know, Andy, if there's anything or more you want to add on that.
Only just to say that those things that are being considered are also being linked in with ICS colleagues across the country, just to sort of get their view on what they're doing as well. So we're kind of taking that wider view.
Thanks, Andy. And then the final one you mentioned, Simon, which was in the letter, was community diagnostics hubs. So yes, we are working on a plan to put together a system approach to what our community diagnostic hubs will look like. There is a small element of national funding for that, but what we're trying to do is tie that together to the community hubs, for example, that are coming out as a requirement from the ICANN work. There's also some community facilities that are required that are coming out of our mental health programme of work across the ICS. So one of my other roles is chairing the system states board. So what we're doing at the moment is pulling out the fact of how do we combine the pieces. What do we need in a community diagnostic hub? What do we need in a community hub for ICANN? What do we need for mental health? We've got quite a lot of estate in this county amongst all the providers. If you bring it together, there is quite a lot. So we're now looking at what are all the requirements for the clinical transformation that we need to do as a system, and how can we use the estate that we have in the county to enable us to do that. So that's the piece of work that we're just pulling together now at the moment. And I think, Joe, Simon had some specific questions for you in terms of the waiting list at Northampton. Shall I hand over to you?
Yeah, thank you. So in terms of 52 weeks, our trajectory is in the pack. We're predicting still to have 52-week waits by September. It's 78 is the prediction. To clear at 52 weeks, our prediction is December. So I'm still expecting us to have 52 week waits by September, but they will be significantly reduced, as will the patients over 45 weeks and 40 weeks, which will help us continue to achieve that. If we can do that quicker, we will, but that will be based on us having extra capacity. But that relates back to the cancer question as well, because cancer referrals have increased, as I referenced earlier, in March and April. Our cancer trajectory is based on the legacy patients we have in the back row currently. So we're predicting to hit the cancer performance in June, but over the summer it's variable, but it's still over 80%, 83 in July, 85 August, 84 September. However, in terms of someone asked a question earlier about clinical prioritization, we may end up prioritizing other patients to go ahead in terms of cancer treatments. So that may affect our legacy backlog and affect where we are in terms of our cancer performance. So I can answer definitely that we will be achieving it in terms of the 62-day wait, because I don't know what I don't know about some of the demand that's coming through the door currently.
And then over to me for the people and temporary staffing. So of course we would like to encourage as many people as possible to come and join our temporary staffing service, and indeed those who may be equally thinking about retiring to do so too. It's under the people processes pledge within the people plan that we're going to work on that across the group, and dare I say indeed in time across the system, as to how we create an attractive temporary staffing offer for colleagues, to make sure that they're not attracted by other potential avenues, agency work and so on and so forth. So we need to create that, and we need to offer consistency. One of the things that we found in the winter of last year was the inconsistency that we have between our hospitals, and that was part of the reason for it being in the people process pledge. And dare I say, we haven't even mentioned in the plan the situation with regards to the vaccination centre. So we are also in NGH the lead employer for the vaccination centre, and we will continue to support that model around the workforce, which is also based on temporary staff. So just in terms of an additional ask for colleagues, We're also asking colleagues to support the vaccination programme. And that's not solely from NGH colleagues. We've got colleagues across the system, primary care, NHFT, KGH helping. But that is an additional pressure that we're also asking people to work on from a temporary staffing perspective. But as I say, overall, it's absolutely something we recognise as part of the People Process Pledge. And we need to have a consistent and good offer to ensure that people want to continue to stay working or indeed join our temporary staffing services.
Okay, thank you. Rachel.
Yeah, I think it's a really, really good piece of work because it's so clear that the involvement from everyone has been listened to and that everyone has signed up to this. I also just want to pick up on something Joe said about clinical priorities, because I remember a while back we had a discussion, it might have been at CPC, and reminded ourselves that actually making cancer a priority would inevitably end up with some difficult decisions. And it just strikes me that we are now at that point of having those difficult decisions, maybe in a different context. But I still firmly believe that we cannot do everything that we would want to do. But yeah, I think that's just a comment from me. Thank you.
Okay, any other final comments? No. Yeah, it's a good plan. I think people have said that it's gone through Performance and Finance, Finance and Performance Committee. It's been through People Committee. Like all good plans, I'm always reminded of, I think it was General Schwarzkopf who said that all good plans immediately fail on first contact with the enemy. And the enemy in this case is COVID. And that's COVID worldwide, when you hear Mark talking about the impact in India on our recruitment plans and so on. So it clearly is a plan that brings a lot of things together. Realistic by Joe a lot of the time about what our staff are willing to do, prepared to do. And of course, they must have holidays this year. Many of them have gone through a very, very difficult time in the last year. So we have a plan. It's been through those committees. Can we just get the board to ratify that plan for the first half of next year, recognising that there is a lot of work to be done to prepare us for the second half of next year. And we have had conversations with our Finance Committee non-execs and directors, and we will be looking hard at that as a group and the opportunities that that offers for efficiency. So can we have approval to the plan, please? Thank you very much. That will go to Kettering Board tomorrow, and hopefully they will also approve the plan so it becomes a group plan going into a system plan. So thank you very much for that. Rachel, your hand is still up. I'm sure that's a legacy hand. Thank you, everybody. Item 11, Assessment and Accreditation for Nursing Excellence. Sharon.
Thank you very much, Chair. Nursing midwifery assessment and accreditation has been in place at the Trust for the last few years. It provides assurance to patients, staff, divisions, Trust Board, and to our regulators that optimal standards of nursing care is being delivered consistently and reliably by our healthcare workforce. Unfortunately, due to the pandemic at the beginning of 2020, we suspended assessment and accreditation as a complete tool. But what we did do was we took standard 5, which was infection prevention. We enhanced that, and that really helped us as we went through the pandemic in monitoring and assuring ourselves of the standards of infection prevention care. For those board members that aren't familiar with assessment and accreditation, it's a framework that's been developed to align with the CQC care standards, the 6 C's, which is compassion in practice, vision and values of ourselves, and recognise the AHP contribution. Within our framework, we have 15 core standards, which are measured using 6 processes or methods: observation of care in the environment, review of documentation and outcome data, and discussion with patients and staff. Each assessment and accreditation visit is led by a lead nurse for quality assessment, and the outcome of each assessment is given a RAG rating dependent upon the scores that are given during the course of the assessment. Further details outlined in the SOP, which is in the board papers. But to note, when the wards have achieved 3 green, they can apply for blue status. That's a real achievement. And pride is also in place very much within the team that they are going for blue. They come and the team is invited to come and present to a panel the work that they have done and the reasons why we should accredit them with blue status. And I have to say, the panel members are quite diverse, both internally and external to the organisation. We have our chief executive as part of the panel and a representative, Ned. And I know that Anne has provided a lot of support to us during the duration of us operating assessment and accreditation. If the panel decides that they should be put forward to blue status, the request is made of the board. And the team, or particularly the leader, will we will make a decision as a board as to whether we are going to grant blue status, and the leader will be invited to come to the board and receive the recognition. The ward leader is also entitled to wear a different trim on her uniform, which really makes them stand out, and they're really proud. So the reason I'm bringing this today is that we now feel the time is right. There's a real strong appetite to reignite and recommence assessment and accreditation as part of our recovery process, really, for COVID. We've reviewed the tool, we've refreshed our standards in light of the most up-to-date CQC standards. We've looked at our patient experience feedback, we've looked at complaints, and we've looked at the data performance that's been ongoing over the course of the last year. We've discussed the proposal at length at Nursing Midwifery Board. We've got our ward we've had our ward sisters undertake self-assessments as a starting point, and the outcome of that's included in the papers. And the other thing that I've done is I've taken the best possible care as part of our legacy and just changed that title to Nursing Care Excellence. And we've also updated the SOP. So we're ready to go. We're really excited. And the reason for bringing it to board today is to ask you to note and support the restart of assessment accreditation, but also to recognise that this is going to form a key part of our group quality objective going forward, where we've outlined our plans to develop a multi-professional tool which connects to nursing excellence across both organisations. Thank you, Chair.
Okay, thank you for that. I'm sure the board will be happy to do that. There were some hands flashing. Where are we going? Yes, Mark and then Matt.
Thank you, Sharon. Thank you, Ellen. Of course, I'm fully supportive of the approach indeed, and of restarting the accreditation process, Sharon. And I appreciate that we haven't yet launched the group values, but my request would be when we do is how we incorporate those into this assessment and accreditation process too, because that's going to be really important in terms of consistency and monitoring and measuring those behaviours. So I appreciate they're not here yet, but it's just something for the future for us to incorporate into this document. But very supportive.
Thank you, Matt, and then Anne, and then Jill.
Thank you, Chair. Thank you, Sharon. As you know, I'm fully supportive, and I'm also really excited, as you allude to towards the end of the paper, developing this from being a nursing tool to being a proper clinical multidisciplinary tool, so we can talk not just about nursing care excellence, but about care excellence full stop. Really looking forward to that. Thank you.
Thank you.
Hi. So yes, I just wanted to endorse everything that Sharon said, having sat on the panel. And I think, in these times when we're asking more and more of our staff to have a programme that recognises their efforts is really important, and also to keep standards high. And I also think it gives you an insight into, because they're little mini cultures, the ones that achieve blue status, the reasons why are they have fantastic leadership. They involve their staff, they empower them, and they recognise and support them. So I think the more that we can get blue wards, then the better overall for staff and patients.
Thank you.
Jill.
Yes, thank you, Chair, and thank you, Sharon. Yes, it's very exciting and really good news that the temperature is right to start back on this work, because I think it does energise people, particularly when they do achieve blue status. Two questions, if I may. One is, does it not cover midwifery as well as nursing? And secondly, presumably this is very important in terms of pathway for excellence and achieving that second time round.
No, absolutely right. It is also, it's also going to be pivotal in terms of our evidence for pathways. So thank you for raising that. We have midwifery, yes, it will include that. I think if you pick up in the paper that the tool had been adjusted to take into consideration midwifery, and we were going to be doing it at the beginning of 2020 in terms of rolling it out, but that obviously has been suspended. So by the time we get to Q3, Q3 this year, we will pick up maternity.
So just a bit worried about the title then, Sharon.
We'll amend the title accordingly, Jill. No worries. I don't think our midwives would let us get away with it.
No.
Okay, thank you for that. Any other comments? No, I don't think so. My only comment is I don't want you to take this in a negative way, but the value of these kind of excellence frameworks is in the rigor of the assessment. If people get them that anybody thinks or shouldn't, then the whole thing starts to diminish. So I would just encourage people to be really rigorous and to make sure the standards are upheld. And I don't think the standards should drop just because of things like a COVID pandemic and so on. So it seems to me that the standard is an absolute, not a relative standard. So just encourage people to make sure we end up with a situation where everybody is content with awards to particular wards or departments. Right, thank you for that. One of the bigger strategy areas, we talked about it in my introduction, nursing midwifery, Jill, and allied health practitioner strategy. Now, we do have a lot of strategies, and you could argue that some of them are more important than others, which is undoubtedly the case. There is a hierarchy, but there are, as I said earlier, over 3,000 nurses, and when you add in the AHPs, that takes us to well over a third of our staff. So a big issue in terms of how we maximise their use, clarify what we want of them, and encourage their recruitment and retention. So, Sharon.
This is a paper that is not, the board are familiar with this paper. The draft strategy has been shared at various subcommittees. We've talked about it in our joint group with our colleagues at Kettering. And it really is with immense pride that I can sit here today. And I know that Leanne from Kettering would, if she could, have joined me in presenting this today as a piece of work that we have undertaken across both organisations. We've developed it for the first time to incorporate not only midwives and nurses, but also allied health professionals. And to developing the strategy together, we've also communicated with over 1,000 members of that team. And one of the real things that came out of wanting to develop our strategy was that those staff wanted their voice to be ignited. And what we've really tried to do in pulling the objectives together, the key deliverables that we want to work through over the course of the next few years, is to strengthen ourselves as a group, but also to make sure that those nurses, midwives and AHPs really have their voice raised and as I've said, ignited. So the strategy is as it is, and as the chair has said, what's really important is that this is not a strategy that stands alone by itself, but also it links very closely in with the strategy, with our academic strategy and our clinical strategy, as much as our vision and values. We've worked closely looking at our key deliverables over the first year. And one of the things that will do is to help bring us together as two nursing, midwifery and AHP organisational teams, because for some of the standards that we have here, we are very close, and others we're further apart. But what we really want to do is focus on bringing our positions together over the course of the next year. So recognising that we still have to do some artwork on the document, in terms of the content, I'd like to ask the board for their approval that this is an NGH perspective, nursing, midwifery and AHP strategy for the forthcoming 3 years. And this will be going to our Kettering board tomorrow, where colleagues will be asked the same question.
Comments or thoughts on that? The board did see this in informal development sessions, so they do know about it.
And I think we can be confident that it is not incompatible with the other strategies that are being laid out, whether the people strategy or the clinical strategy or whatever. So anybody want to comment at all, or are we just happy to say thank you very much, Sharon and Leanne by default? Yes, we are. Okay, thank you very much, Sharon. Leanne, we can take that as approved. It's a good strategy and it covers a large part of our workforce. Annual self-certification, Claire.
Thank you, Chair. This obviously by its title comes to the board on a yearly basis, and we are required to comply with these conditions even though we are exempt from them as we are not an FT. This has been to the Finance Committee, who have approved positive confirmation for each of the licence conditions, and now comes to the board for its ratification. We don't have to submit the results to NHSE any longer, but we do have to publish it on the Trust website, and they are audited by NHSE on request. So it's here for the board's approval, please, or any comments.
Anybody wants to argue with that point? Nope, good, you can take that as approved. Thank you very much. Board Assurance Framework.
Thank you. This is the document for the last quarter of the previous financial year, and it is the last iteration in its current form. Going forward, the new iteration of the BAF will include the group priorities and risks associated with the achievement of the group strategies, and that will be coming back to the July board. Work is ongoing with Richard, my counterpart at Kettering, regarding the BAF design, use of common language, and reviewing our risk management strategies, etc. So this is here now just for information. It has been through all of the board committees, and the comments I'd just like to make on the changes in this iteration is that there has been a number of risk scores which have reduced, and that is overall due to the removal of the gaps in control over the last quarter, and also the delivery of the financial plan, taking the overall risk score from 236 to 206. I'm happy to take any questions.
Okay. And are there any questions on risk or on board assurance framework anyway? No, I'm pleased that we're changing the format. I think it's important as a group that we see our risk and board assurance framework in the same style and layout. I think too, as we move forward into that, we need to be more active in developing plans to reduce the risk, particularly those that score highly. And I think we've had arguably too many risks sitting in the over 20 category for too long, which is not a place we want to be. So I'm looking for a revised format and a greater level of focus on thinking about the reduction of those risks, which are both likely and catastrophic. Stuart.
Thanks, Chair. I just thought it'd be useful. We've talked at board over the last year. Well, board know we've had a focus on estates assurance and especially on fire. In the last month, we've been able to improve the assurance and reduce the risk on fire because it was our highest risk. So all that work has now been verified by independent. So we've had independent audit and independent risk assessments that supports the reduction of that risk. So it's quite a milestone to reach for us. So I just thought I'd let the board know that for assurance.
Thank you very much, Stuart. The board did spend a lot of time talking about fire risk or estates risk in general. We've talked briefly at the start about electricity supply, both high and low voltage, I think. And I think we spoke a lot in the past 14 months or so about fire. So it's good to see that those have all come to fruition. Anybody else want to comment on the board assurance framework beyond what I've said? No? Good. Thank you very much. I consider that approved. Group risk appetite, which kind of links to the whole assurance framework and so on. This, as you can see, has been developed in April. Joint board development session, CPC, Collaboration Programme Committee, did discuss this a lot as well. And it's coming here for ratification. And again, I think it's important that this business of risk appetite is not seen as a kind of, oh, well, let's just have a conversation about it and then park it. This risk appetite ought to colour decisions and judgments that people make and committees make going forward. So we just need to to understand the levels of risk it's legitimate to take, and remember to build those in to proposals you're bringing forward, particularly around covering papers and so on, that what you're doing fits with the risk appetite that the board has set on things we're attempting to change. Any comments? Again, this will be a mirrored paper because this is group risk, mirrored paper going to KGH board tomorrow. Any comments on the business of risk appetite and risk?
Could I just add, please, Chair, that this also will be an integral part of the new BAF format. So it will be clear against each of those strategic risks what our risk appetite is. And that has also been agreed.
Thank you very much, Claire. And of course, the art form is getting the risk to match the risk appetite. There's a considerable degree of work to be done in a few areas. Good progress has been made in bringing them down, but nevertheless, it's important that these are not abstract conversations, that they fit with the picture that emerges. Anything about that at all? No. Okay, thank you very much for that. I don't believe we have any questions from any members of the public. No, we don't. Any other business? Simon, you have your hand up.
Yeah, thanks, Alan. I just wanted to take the opportunity, as it's Bola's last board with us in her current role, to thank her very much on behalf of us all for the work that she's done. I think she's made a fantastic contribution throughout what has been one of the most challenging planning rounds. And although I know we're looking forward to welcoming John next month, it feels entirely appropriate to say thanks, Bola. It's been a really great effort, and I know that you will continue to make a massive contribution to the group, but I just wanted to take a moment to say thanks.
Okay, thank you for that. And I'm sure we can all agree with that. You can see some of the symbols going up. Yes, indeed. Thank you very much for all you've done, Bola, and I'm sure we will be seeing you again. Sharon, you have an item.
Hello, please, Chair. I have one question for the board. Board members may remember last year when we looked at the timetable for the upload of our CNST submission. We delegated responsibility to that to QGC. Can I please ask the same question for the board to delegate responsibility to QGC for our submission this year, as the submission date is before our next public board meeting?
I'm sure that's going to be granted. Yes, okay, thank you very much, everybody. The next public board meeting will be on the 29th of July, and it will be in the boardroom at Northampton General Hospital or via Zoom, depending on COVID restrictions. We'll clarify that nearer the time. And I now ask you to pass the resolution that representatives of the press and other members of the public be excluded for the remainder of this meeting in regard to the confidential nature of the business to be transacted publicly, which would be prejudicial to public interest. Silence is assent. Thank you very much. There was a small break now, and the private board will start. It is on a different